Young male patient is lying flat on the bed having a pulse rate of 80 beats per minute. It is of normal rhythm, volume and character. The blood pressure is 110 by 70 mm of mercury. The JVP is not raised. There is no cyanosis, clumping and pedal edema. On examination of the pericardium, there is a visible cardiac impulse at the mitral area. There is no scar, bulging or deformity. The apex beat is displaced in the 6th intercostal space lateral to the midclavicular line, and it is thrusting in character. There are no other heaves, but systolic thrill is present at the apical area. On auscultation, the first heart sound is soft and second heart sound is normal. In addition, there is also third heart sound present. There is a low-pitch mid-diastolic rumbling murmur at the apical area, best heard in expiration with the patient in left lateral position. There is also pansystolic murmur present at the apical area, which becomes loudest during the expiration and it radiates towards the axilla. The lung fields are clear to auscultation. There are no signs of the pulmonary hypertension. There is no stigmata of the infective endocarditis. The diagnosis is mixed mitral valve disease, and I think the dominant valvular lesion is mitral regurgitation, as evidenced by the thrusting displaced apex beat, soft first heart sound and presence of the third heart sound. The diagnosis should be confirmed by the echocardiography. A young, thin female patient is lying flat on the bed having a pulse rate of the 80 beats per minute. It is regularly irregular of low volume in normal character. The blood pressure is 110 by 70 mm of mercury. The JVP is not raised. There is no pedal edema, cyanosis and clumping. There is no malar flash. On examination of the pericardium, there is a visible impulse at the apical area. There is no scar, bulging or deformity. The apex beat is undisplaced, lies in the 5th intercostal space medial to the midclavicular line. It is tapping in character. There are no other heaves and thrills palpable. On auscultation, the first heart sound is loud and second heart sound is normal. There is presence of an opening synapse in the early diastole, which is followed by a low-pitch mid-diastolic rumbling murmur at the apical area, best heard in expiration with the patient in left lateral position. There is also presence of a pansystolic murmur at the apical area, which becomes loudest during the expiration and it radiates towards the axilla. The lung fields are clear to auscultation. There are no signs of the pulmonary hypertension. There is no stigmata of the infective endocarditis. The diagnosis is mixed mitral valve disease, and the predominant lesion is mitral stenosis, as evidenced by the low volume pulse.